Hi, I'm Ryan from the University of Wisconsin, and I'm going to be presenting about pulmonary artery stenosis, specifically comparing the effectiveness of an early intervention using a small diameter stent compared to a delayed intervention with a large diameter stent. Pulmonary artery stenosis is one of the most common complications following heart surgery for congenital heart disease early in life. To the right, you can see an angiogram of a PAS patient who has a stenosis on their proximal left pulmonary artery, and this really negatively affects blood flow to that lung, and you can see that the vessels distal to the stenosis haven't grown normally. Stent interventions are preferred over surgical approaches because the early attempts at surgical approaches had really poor outcomes, but historically stent interventions have been limited to older patients due to available technology. However, recently, with newer small diameter stents on low profile delivery systems that also have the capacity for stent expansion as the patient grows, interventions are now being performed in infants who, at least theoretically, have greater capacity for growth of the lung and its vasculature. And as a side note, these are typically biliary stents or sometimes coronary stents that are being used. But the effectiveness of these early interventions isn't yet known. So the aim of this study is to compare early versus delayed interventions in a swine model of pulmonary artery stenosis. This is our study timeline. So we have 4 groups: a control group, the stenosis group that receives no treatment, a delayed intervention group that has a stent placed when they're about 30 kilograms, and then an early intervention group who has a stent placed when they're only 5 kilograms, and then when they're 30 kilograms has a dilation procedure to expand the stent. And then at the final time point, all the groups have comprehensive CT, MRI, heart catheterization, as well as histology. And so some limitations of this study are we have relatively small numbers in each of the groups. The swine grows much faster than a human does. It only takes 5 months for them to grow to be 60 kilograms. And then lastly, we only used male swine in this study. To underscore why the stent dilation procedure is so important and why these stents need to be able to be dilated, so you can see here the initial stent is placed and everything looks fine. But then as the patient grows, you'll actually develop a restenosis as the stent doesn't grow with the rest of the vasculature. So you need to be able to either perform like intentional fracture and then place a new stent, or have a stent that can dilate as the patient grows. So looking at the outcomes of interventions on the PA diameter, the proximal, where the stenosis or stent is, the stented region still didn't reach normal size compared to the control group. And immediately adjacent to the stent, the LPA also didn't grow to be normal size. However, further away from the stent, more distal in the LPA was able to grow to normal size. And we didn't see any differences between the early and delayed interventions for the diameter of the main LPA or the LPA branch arteries. Now looking at the effects of interventions on the heart. Stenting reduced the pressure gradient over the stenosis, which then in turn reduces pressure in the right ventricle, which is good. However, both of the intervention groups had smaller ventricles. And this actually happened on the left side too, which is interesting. And again, we didn't see any differences between early and delayed interventions. And actually the only place where we saw benefit to early interventions was looking at lung histology, where the early intervention group had fewer abnormalities that are related to low perfusion of the lung. And so the takeaways are that stent interventions have clear benefits in the context of PAS, but there still are differences between the intervention and the control groups. And early interventions weren't more effective than a delayed intervention, which was actually the opposite of what we were expecting. So this suggests that the prudent course of action is to wait until a patient is large enough that a stent could be placed safely. However, corollary clinical studies are needed to find out if these results apply to humans. And so for what's next for improving outcomes for patients, perhaps we need better pediatric devices, or another approach would be to give a pharmaceutical intervention with the stenting. I'd like to thank my funding sources, and if you have any questions, I can be reached at my email address. Thank you.